All right. Welcome, everybody. We are very happy to have you all with us today to have the big launch of our report looking at the impact of COVID-19 on TB programs in Canada. So before we get started, just want to go over a few logistics. Lee's letting people in still as they arrive because there's still people trickling in. Now, I know you're all probably very familiar with Zoom, but we do ask that if you're not speaking, keep yourself muted. If you feel comfortable doing so and turning on your video, it's really nice to see other human faces, even if they're just on screen. So please do turn on your video if you're comfortable doing so, especially for whenever we have more of an open dialogue and we can see one another. We're going to be spotlighting different speakers throughout this session. So you shouldn't have to worry about toggling between speaker versus gallery view, but if you want to do so, that's up in the top right of the black box of your Zoom screen. Just click view and you can have a little explore there. If you are speaking and giving an address at some point today, make sure that you've named yourself by your actual name so that we can find you and spotlight you ahead of your speaking in an intervention. All right, so the agenda for today, what you can expect, we're going to pass over shortly to Dr. Elizabeth Ray to give some opening remarks. Then you're going to get an in-depth presentation of our findings delivered by Lena and Alex, the co-lead designers of this project and writers of this project, who we're very grateful for today. And then we'll have a little bit of an opportunity to get some question and answers from the audience. And lastly, we're going to close with some closing remarks from different speakers who are going to respond with some reactions to the findings and calls to actions of our report. All right, so before we get started though, I would like to pay respect to the Algonquin people who are the traditional guardians of the land where the Office of Results Canada is in Ottawa. We at Results and Stop TB Canada acknowledge the Algonquin people's long-standing relationship with this territory, which remains unceded. And now, land acknowledgements, as they've become termed, can stimulate critical reflection, learning, and healing if done meaningfully. But as I was reminded in an article published just yesterday in the CBC titled, "What's Wrong with Land Acknowledgements and How to Make Them Better?" there is a risk of them becoming superficial, performative, and problematic. Genuine words must be complemented by action. And taking the initiative to undertake this initiative and share our findings with you today is one example of taking meaningful action. The findings of this project will not just bear witness to the impact of the pandemic on TB programs in Canada, they have and will continue to inform our calls to action and advocacy priorities moving forward. And we at Stop TB Canada really hope that everyone here today will join us in taking action to do what is required to make sure everyone affected by TB in Canada gets the care and social support they need, and TB programs and frontline staff have the resources necessary to deliver quality care in safe environments. All right, now over to you, Elizabeth, to kick us off with opening remarks.
Thanks, and thanks to you all for taking part today. I'm Elizabeth Ray. I'm a physician working with the TB program at Toronto Public Health and the current chair of Stop TB Canada. So we undertook this survey with the help of colleagues at the University of Edmonton in the context of escalating global concerns about the impact of the COVID-19 pandemic on TB. There was a similar survey that was done last summer, in part by colleagues at McGill, and WHO released the 2021 Global TB Report just in the last few days that documented the first increase in global TB deaths for over a decade. Last year, over 2019, there were more than 100,000 additional people died of TB, which has not happened for a long time. And the first serious drop in people accessing TB treatment by about 20%. So those are devastating setbacks in the collective effort to get to TB elimination. Until now, there hasn't been any real Canadian status update. But we do know that there's been a massive diversion of public health resources to fight the COVID pandemic. There's been massive disruptions of clinical healthcare services and a whack of social hardships associated with the pandemic as well. And meanwhile, of course, TB hasn't disappeared. Just this week, 2 First Nations in Saskatchewan declared TB outbreaks. It's going to take considerable resources from the local health authority as well as Indigenous Services Canada to tackle that. New people continue to be diagnosed with TB in Inuit Nunangat through this pandemic, and immigrant Canadians in our southern cities continue to need TB care. So the other kind of critical piece about holding this webinar and releasing this report now is that we're in a critical window to take stock of TB and TB care in Canada 18 months into this pandemic, and to get to work now on getting TB care and TB programs back on track as part of pandemic recovery planning. We have a new federal ministers and members of parliament coming into place this fall. We're right now into the budget planning for next year at all levels of government and organizations. So getting TB care onto those agendas is really critical. And we also have, almost 75% of all Canadians immunized against COVID now. So there's at least the hope that we're coming out of this pandemic finally, and making sure that care for Canadians with TB is part of that recovery agenda, is a big part of getting us back on track for TB elimination. So we hope this survey will make a timely foundation for us all to come together and take action and demand action. It has always been a collective effort to tackle TB in our communities. So with that, I'm going to turn it over to Lena and Alex.
Thank you, Elizabeth. Lena, can you share your slides?
Yep.
Okay, so thank you everyone for being here. I'm Alex Zimmer, and with my colleague Lena Faust, we're going to be presenting the results of the survey we conducted on the impact of COVID-19 on tuberculosis programs here in Canada. So as Elizabeth already highlighted, the Global TB report was recently published a couple of days ago, and I'm sure many of us have come across the report and seen the statistics. So it comes as no surprise that COVID-19 has really set back efforts towards eradicating or eliminating TB globally. Some of the statistics that Elizabeth already highlighted include just a major drop in people accessing TB care and just a major surge in TB deaths in 2020 compared to 2019. And so while a lot of research has focused on the impact of COVID on TB in high burden TB settings, there were some anecdotal reports coming out from TB programs here in Canada that COVID was also causing disruptions within our country. However, there is a complete lack of available data to back these anecdotes. So the last TB in Canada report was published in 2019 and reflects or summarizes data that was collected in 2017. So that's 4 years ago. And so this lack of up-to-date epidemiological data is really inefficient for informing resource allocation and guiding public health action to strengthen TB services in the wake of the COVID-19 pandemic. And there really is no question that TB is still an issue here in Canada. As Elizabeth already highlighted, there was a TB outbreak reported among First Nations communities in Saskatchewan earlier this month. And so it was really these combined anecdotes as well as the lack of data that that compelled us, the Stop TB Canada network, to conduct this survey. So I'm just going to briefly talk about some of the methods we used to collect the data. We surveyed TB program leads, TB staff, and people affected by TB across Canada. We used Likert scale questions and open-ended responses. And when possible, we collected aggregate, provincial, and territorial quantitative data for active TB case notifications and LTBI management. And surveys were made available in both English and French. I will just point out that this report is intended for advocacy purposes only. Participants were informed about this purpose and their participation was entirely voluntary. No individual identifying information was collected, and provincial and territorial affiliations of the respondents were not reported in the final report. And finally, there was no funding received for this initiative. So this is just a quick snapshot at who we collected data from. So we received responses from 37 program leads and TB staff and 6 people affected by TB. And the majority of responses were from Ontario, as you can see in the figure. But you can also see that the responses overall were quite limited. So experiences that are reflected in the report may not represent the experiences of Canada as a whole. But this report at least gives us some preliminary insight as to what is going on in terms of TB care and services in the face of a lack of alternative sources of information and data. So I'm just going to dive into the Likert scale and open-ended responses that we collected. So we see here an example of a Likert scale figure that is published in the report. And so in red, we have the level of agreement with the statement, which represents a worse outcome. And in green, we see the level of disagreement with the statement, which is a better outcome. So in terms of diagnostic delays, 41% of TB program leads and TB staff reported that TB diagnoses were significantly delayed. And there was one very powerful quote from a TB program lead who said that a classic case of pulmonary TB in an elder who presented numerous times with pleurisy and cough over months and had 3 COVID-19 tests, but had no TB assessments or testing. They were finally picked up to have smear positive TB, but they died during treatment. Moving on to the diversion of staff, approximately 2/3 of program leads and TB staff acknowledge that they or their colleagues have been diverted away from TB towards COVID-19 related work. And many TB staff highlighted in their open-ended responses that some of the TB services really suffered during COVID-19 due to these diversions. Approximately 2/3 of TB program leads, 56% of TB staff reported that the majority of TB services had gone virtual during the pandemic. And although some staff saw this as a positive change, there were a few that found that there were some limitations to virtual care. And so one example is from a person affected by TB who noted that because of the virtual care format, doctors may not know what the patient's issues is, which may in turn delay treatments. And then a TB program lead highlighted that it was very difficult to implement virtual care in isolated communities due to poor internet connectivity. In terms of quality of care, 41% of TB program leads and 38% of TB staff felt that there was a significant decrease in the quality of TB care provided during COVID. And one TB staff highlighted that they had seen some of the worst cases of active TB during the pandemic, which was distressing. For quality of care in terms of access to medicine, 1/3 of program leads and 28% of staff reported significant delays in the delivery of TB medication during COVID. And many of these delays really impacted remote northern communities when the number of flights into these communities decreased significantly during lockdowns. So LTBI care was deprioritized in a majority of provinces. So nearly 60% of program leads and 68% of staff reported that LTBI treatment was significantly scaled back during COVID. For active case finding, 41% of TB leads and 36% of staff reported that active case finding activities were significantly hindered during the pandemic, and one program lead found that they had to scale back to doing passive case finding instead. Similarly, 58% of program leads and 56% of staff reported that contact tracing activities were hindered, and some of this was done in an attempt to limit exposure to COVID-19. And finally, for the evaluation of referrals from immigration, 17% of program leads and 32% of staff agreed that the evaluation of referrals from immigration were significantly hindered. So now I'm going to pass on to Lena, who's going to talk a bit more about the lessons learned, the quantitative data, and the calls to action.
Thanks, Alex. So first, I'm going to go through lessons learned and resources needed to continue to provide quality TB care during the pandemic. So first of all, respondents reported several ways in which TB programs adapted to the pandemic. This included, for example, task decentralization. So this included advocating for having additional dedicated TB nurses and also hiring new DOT workers to lower the workload for nurses, as well as the cross-training of staff in order to cope with the redeployment of staff to COVID-19. And respondents also reported increased interorganizational collaboration. So respondents reported, for example, forming new partnerships with organizations in order to be able to provide services more efficiently with reduced capacity. And it was also reported that programs prioritize tasks. So for example, focusing on case finding and contact tracing and less on other program activities. However, this also was a disadvantage given that, for example, a program lead noted that it led to a loss of momentum for Ltbi elimination work that was scheduled and a lot of TB priorities being put on the back burner. However, in a more positive development, another way in which programs adapted was, for example, through providing more patient-centered care during the pandemic. So this included, for example, providing cell phones or food support to patients. In terms of in terms of solutions and resources needed to continue to provide quality TB care during the pandemic, respondents mentioned the need, for example, for access to tools such as electronic charting, as well as the need to expand outreach. And certain organizational improvements were also noted. For example, the need to reconstitute the TB Advisory Committee to the Public Health Agency of Canada, and the need for an increase in staff to deal with both TB and COVID, particularly in First Nations communities. There was also a need for increased education and public awareness around the fact that, for example, people should continue seeking care for non-COVID conditions during the pandemic. And respondents also mentioned a need for updated data on TB, which we have mentioned previously as well. And lastly, there was a need for, respondents called for increased funding for dedicated to TB specifically. Next, I'm going to list some of the opportunities that respondents listed in order to leverage lessons learned from the COVID-19 pandemic and to apply this to improve TB care. So first of all, again, tools and systems needed, such as electronic charting. And second of all, lessons learned included numerous things. First of all, respondents noted that the pandemic served as a wake-up call to the importance of the social determinants of health in shaping vulnerabilities to disease, and that this should be leveraged in order to take action on reducing barriers to access to healthcare, for example, for newcomer communities, for example, by reducing wait times for provincial healthcare coverage. It was also noted that the pandemic highlighted the need for flexible approaches to care, which should also be applied to TB care. Especially, respondents called for more creativity in providing care to remote communities, and also adapting the Indigenous-led COVID-19 response into an Indigenous-led tuberculosis response. Lastly, in terms of organization, the pandemic also highlighted the need for more efficient contact tracing and how this should be applied to TB. And in terms of lessons at the public level, respondents noted that due to COVID-19, the public generally was now more aware of infectious disease transmission and steps that were taken, that can be taken to reduce transmission. Now I'm going to briefly go over some of the quantitative data that was presented in the report. So this graph shows monthly incident active TB cases in 3 provinces and territories, the Northwest Territories, British Columbia, and Saskatchewan for 2019 and 2020. However, monthly counts were not available for other provinces and territories, although annual counts were available for 6 programs, and they're shown in the table next to the graph. So as you can see, these are very limited data, and therefore we can't conclude whether case notifications significantly decreased during the pandemic, which again highlights the urgent need for timely and accessible reporting of TB data across Canada. Although considering the reduction in diagnostic capacity for TB during the pandemic, the data may suggest that there are a significant number of cases going undiagnosed, but we would need further data to confirm this. And it's just important to note as well that other quantitative data were also collected, for example, on LTBI management, so LTBI treatment starts, and also the evaluation of referrals from Immigration and Citizenship Canada. However, these data were also very scarce. For example, no programs were able to provide information on referrals from immigration. So this again underlines the need for more accessible data. And so now, taking into account the qualitative and quantitative findings of the report, we would like to make the following calls to action. So first of all, I feel like I've repeated this many times, but the first call to action is on the need to update TB data and to transparently measure progress towards the TB elimination targets to which Canada has committed. So we call on the Public Health Agency of Canada to make this data comprehensively and to make comprehensive and timely data available, and also for TB to feature in the Pan-Canadian Health Data Strategy. Next, we call for increased non-medical support for those affected by TB, which includes food support, income support, and mental health services being integrated into TB care. And the report has also really highlighted the need to balance the COVID-19 response with the ongoing need to provide services for TB. So this includes ensuring that TB is considered in respiratory screening guidelines, especially in the context of a negative COVID test and persistent respiratory symptoms, particularly in communities with a high incidence of TB, so that cases are not missed and the diagnoses are not delayed, the way that we have seen from some anecdotes in this report. Next, it's important to balance the advantages with the limitations of virtual care. It does provide additional flexibility, but we need to keep in mind the limitations, especially in settings with low internet connectivity, and needing to keep in mind the fact that in-person evaluations remain important in many cases. Next, it's also important to address the backlog of LTBI management that has been created by the COVID-19 pandemic, especially given that the management of LTBI is an important aspect of TB control in low incidence settings, such as Canada. We also need to ensure sufficient human resources for TB programs and ensure that we apply lessons that have been learned from COVID-19 to improve TB care. Next, we also call for renewed political and financial commitment to TB elimination. And this is especially important in light of the fact that Canada has failed to meet its TB research funding targets as agreed to at the United Nations high-level meeting on TB. So especially in light of the setbacks due to COVID-19, it would be important to increase financial commitment to ending TB. Lastly, we would like to call for taking action on health inequities in Canada, especially the inequities that allow TB to persist in Canada today. And specifically, we would call for integrating TB care into plans and budgets for addressing newcomer and Indigenous health, for example, through safe housing and food security. And now we're just going to open it up to questions and discussions. And we'd like to thank you very much for giving us the opportunity to present these findings. And Robin is now going to moderate the discussion. Thank you.
Thank you so much. Okay, now this is where everybody might want to shift their screen to gallery view. So top right view gallery so we can see one another. And if you're comfortable doing so, please turn on your video so we can see you. First, start thinking about your question, but first I'd love to see some emojis of hand clapping from everybody. Big shout out to Alex and Lena, who we really would not have been able to do this really important piece of work if they weren't on our team and supporting the Stop TB Canada steering committee and all the amazing ways that they do. So big round of applause to them. And also thank you to all the members on our steering committee. It wouldn't have been possible to tap into our steering committee members' networks if the steering committee didn't exist, and to use their expertise to provide strategic oversight and guidance in the design, implementation, and write-up of this report. So thank you to everybody involved. We really appreciate it. And I just want to flag that we have more than 15 minutes actually, we're now for question and answers with the audience. If you have a question, raise your hand or type your question in the chat box and we will come to you. Lena and Alex can take questions. I'm sure Elizabeth is standing by to support as well. And if Courtney's here, I'm sure she can help too. If we don't get through everybody's questions, we do have time after this session. So we're gonna have a hard stop at 2, but a number of us are gonna stick around and take additional questions if anybody wants to dig a little bit deeper into the findings of the report or workshop any of the calls to actions and next steps that we as a community can take to make sure that these calls to actions are implemented. Okay, so without further ado, I see a hand already raised from Pamela. So over to you, please feel free to unmute and ask your question.
Yeah, thank you very much. Just in terms of data or getting more data, which we could argue we do or do not need, I was wondering if anyone is involved, and if not, would it be a good idea to look at CIHI data about TB? I guess this would be people with TB who are admitted to hospital. You know, the severity of illness and the types of illness, late diagnoses, and compare the COVID time with the previous year or 2 or 3 years. Is that, first of all, is anyone doing that? And secondly, is that worthwhile to add to the argument that there's a problem and we need to do something about it?
Yeah, so we did actually have some conversations with CIHI about this, about what kind of CIHI data we could pull into this. It was a great conversation. It actually led to part of our work with the Pan-Canadian Health Data Strategy. I'm mangling the name of that group, which was great. The big limitation of CIHI is kind of what you said. It really will focus on hospitalization data. So it may only capture a piece, but it is obviously a really critical piece. So yeah, that is something that we've talked with CIHI about. I do want to say, I don't think we need to, there's enough to work with that I don't think we need to wait for CIHI data about hospitalization to say there's serious gaps over the last 18 months in TB care. But yes, you're right.
All right, thank you, Pamela. And Mandeline Nash, I see you have a question. When you're asking your question, it would be helpful to say a little bit about where you're working or what organization you're representing too, if possible.
Sure. Oh, hi. Thank you so much, Alex and Lena, for undertaking that important work and sharing your findings with us and to everyone else involved. My name is Madeline. I'm work for an organization called Sea Change, and I know many of you from the McGill TB community as well. I just noticed you didn't have any respondents from Nunavut, which seems like a rather large gap given the burden there. I was just wondering if you could comment on that. And obviously their data is missing as well. Thanks so much.
Thanks so much, Maddie. Yeah, that was definitely one of the big limitations of our survey. So we weren't able to get responses from all provinces and all programs. So that is really a big limitation, especially given the burden in Nunavut. So yeah, it would just, I think, be good to, if it were possible to do something like this on a larger scale with more resources in a more official capacity, that would for sure be important. So yeah.
And Lena, just as to dig a bit deeper on that, did we do outreach to all provinces and territories? I remember a question of translating our surveys into Indigenous languages too, and it didn't end up happening because we didn't have resources. But if you want to maybe speak a little bit to that outreach effort.
Yeah, so I think if we were to do this again with funding, then it might be important to translate also into Indigenous languages and to get more responses that way. That might have been one of the barriers to getting responses, as well as thinking of better ways to disseminate the survey, which I think was at this point very sort of provider focused. So that might be something to change as well if this were to be done again on a larger scale.
Thanks.
And continuing to, I'll just make a few additions, continuing to strengthen our relationships within the Canadian TB ecosystem. So Stop TB Canada, as I'm sure many of you know, has existed for quite a long time, and it's gone through different iterations and levels of engagement from the community. But really, in the last year, we have put a lot of volunteer time and effort and resource into reinvigorating this network. So we're in a reinvigoration phase, I would say, a rebuilding phase, a reestablishing Stop TB Canada as a network within the Canadian context. So that work is ongoing as well. All right, and I see a question in the chat box, a couple actually, from Alex Gilbert. Are you sure your lab partners would get annoyed? Okay, it's a question about one of our calls to action. It says, adapting Indigenous-led COVID-19 response to the TB response. As the reduction in screening and capacity, especially for at-risk communities, do we know if following a negative COVID test, is there anywhere where we actually capture data or pursue follow-ups for TB screening? Or is that still one of our wishes?
I'm not sure if maybe someone who's more involved in direct sort of patient care wants to take this question, or?
It's Elizabeth. So I think what that issue speaks to is a couple of things. One is the sort of diagnostic bias that can happen during a pandemic where everybody's really fixated on COVID. And sometimes, you know, it can be tempting to forget that a bunch of other stuff can still be happening. So that's one issue, which is really kind of a clinician outreach reminder issue. But the other piece, it kind of, so I guess, is an infrastructure piece surrounding that. That if we are talking about high burden, high incidence TB communities, having robust systems in those communities that make sure, even independent of clinical biases that may or may not be happening, there's some infrastructure to make sure that automatically people who are a household contact to someone with TB would automatically flow into a contact investigation, LTBI workup and treatment pathway. And then the other piece, of course, is ongoing issues about, you know, robust clinical tools and EMRs that would support that kind of infrastructure, data systems so that we actually know what's happening. So it's kind of a three-parter, I think, on that one.
Thanks, Alex. Are there any other questions from the members of the audience in the room today? It can be about the findings themselves, the calls to actions, any of our intended next steps for our advocacy priorities as a network or community, anything at all. And I see another good comment from Elizabeth in follow-up to the question from Mandeline, saying, I think not getting input from Nunavut also speaks to the way overstretched public health resources during the COVID-19 pandemic. Cheryl, was that a hand? Go ahead.
Hi, Cheryl here from BC TB Services. I just wanted to comment. It's interesting to I think just to see that everybody kind of suffered the same thing that we did, and the delay in care and the impact to our programs and the steps that we were taking to move forward with things. I actually think that some of the stuff that was kind of great, like I think being able to offer some virtual care for clients and getting them connected with phones and internet and that kind of stuff is been pretty great. I'm interested to know how that impacts our recurrent rates of active disease. Like, are we maybe not going to be doing as good of a job, or is it just as good? So I'm just wondering if anybody else is kind of wondering about that, or if that's something that might be investigated. I guess something we'll look at years down the line, maybe.
Open to responses from anyone here. I think Cheryl's surveying the community.
So we got some fairly mixed responses regarding virtual care in the report. So if anyone wants to jump in with like their experiences in their program, that might be interesting.
I know, I think that BC, we don't do very much DOT here, and I think we're a little bit I think we're a little bit separate from other folks, is that we just don't have the capacity to offer that. And I don't think that in BC that we have any more recurrent rates than anybody else. I think we're fairly low with that. So, I mean, I think having more tools in our toolbox to offer care for TB is good. But I guess I was just curious if anybody else thought that was good or bad, or angst about that.
I see Pierre has his hand raised now, maybe to respond. And Richard, you've unmuted yourself, so we'll hear from both of you.
Yeah, after years of lobbying for video DOT in Winnipeg, like in an urban setting where there's good internet access and, you know, accessibility shouldn't be an issue, and having barriers and all kinds of privacy legal blockages to us moving anywhere, COVID-19 was the silver lining we were waiting for. Not wishing a pandemic on anybody, but because of this forcing us to go to virtual care, all the barriers disappeared. And so now the majority of patients who have access to a mobile device, which is most, even those who we consider structurally disadvantaged, seem to have at least access to a mobile device we can make use of with them. Almost all of our DOT now is at least 60 to 70% is done virtually in the Winnipeg Health region. Challenges, yes, in the remote northern communities, there's no doubt about that, but LTBI care is occurring exclusively virtually in northern remote communities. They're accessing primary care physicians designated to offer that service in Winnipeg. It's done remotely. It came to a standstill during COVID-19, like LTBI managed everywhere else, and it's starting to ramp up again, especially now that we have access to rifampicin again. So for us, the virtual care for TB has been a wonderful addition to arsenal. Everybody's raving about it. The clients, the patients, the public health nursing staff, very positive responses.
That's great. Richard, did you want to jump in?
Yeah, so I mean, something similar. I think, again, looking at the maybe the few positive things, but definitely virtual care, virtual also for research has been a boon. And again, all of the previous barriers that were imposed by whether it was ethics committees or lawyers or others did seem to vanish with COVID. Suddenly it became necessary. And when it was necessary, also reimbursement, practice, you name it, all kinds of things suddenly became possible. And so I think that's a real bonus for patients, frankly, because a lot of care can be given and you can get in touch with people much faster, frankly. They got a question, they don't have to come to the emergency room and wait 16 hours. So I think we should look to continue this, and we should look, if anything, to expand it and find ways to deliver care. I mean, of course, you still want to be able to see people, no doubt about it, but a lot of care can be delivered virtually, and it's frankly more convenient for patients. Obviously, less travel time, less expense, less time away from work. Our non-unionized workers don't have to, they can just, take 15 minutes to make a call. So, I think that virtual care is a bonus. We, from all aspects, it was approved rapidly. Like I said, there were malpractice issues, there were legal issues, not just for physicians, but for nurses as well, that quickly got resolved. And, those are things we don't want to lose. And I think there's other things that we should look at. Someone's mentioned the gene expert, the capacity of public health. The burden on public health has been huge, but the capacity of public health has increased, right? So hoping that the pandemic ends, abates, recedes, it's an opportunity to try to shift people, not the same people back to TB, but maybe more resources back to TB. I think we should also be, advocating for that, so that rather than dismantle the public health capacity and wait for the next pandemic, let's shift the public health capacity to ongoing public health problems. And then that reserve, if you will, is still available. That might be an effective argument, frankly, to make at provincial, territorial, and whatever levels.
And I know the Public Health Agency of Canada has already put out statements, actually this past World TB Day, explicitly stating that they would leverage infrastructure and resources invested in the COVID response for responding to tuberculosis in the Canadian context. So I think we have to push to hold them to accountable to that statement, but there's political indications already laid to support making that happen, which is great. And Alex, I know you might have something to say on this from the global TB report that we did and the paper we recently published. Just want to give you that opportunity to chime in on this discussion before going to Julia as our last question and moving on.
Yeah, I think a lot of what applies in Canada can apply to other settings as well. When I looked at it using the global report, I think it was very similar. So I looked at how COVID-19 hindered people with TB from accessing facility-based dots, and then explored alternative options that were coming up. And video dot was obviously one of the leading alternatives. But again, there were some areas in some communities where accessible internet or data services made it a little more challenging, a little more limiting, but this is something that could also be scaled up and help increase access on a global scale.
Thanks, Alex. All right, over to you, Julia, for the last question.
Hi there. Sorry. Yeah, so Elizabeth was just talking with me a bit in terms of how we rolled out VDOT in Toronto. I'm one of the managers of the Public Health TB program.
Oh, Julia, I'm so sorry to interrupt. We can't quite hear you. I think maybe.
I'm gonna turn off my video. Okay, yeah, sorry. Sometimes the connection's not great. Yeah, I was just chatting with Elizabeth and thought I would pipe in about the introduction of VDOT for Toronto Public Health's TB program, and just add to how it would be great to continue virtual care, and how that is probably the only way we really were able to manage with such limited resources and still stay connected with our patients. So we started using WhatsApp as our delivery system for VDOT because it was the least cumbersome for clients. Most clients already had it and were very comfortable using it, and it gave them the flexibility to connect with us quickly when they needed to. We were in their contacts, and it was very clear picture for us to see exactly what meds they were taking, and we were able to see probably double the number of patients we would normally be able to see, especially probably worse now with traffic in Toronto and trying to get across all areas of the city, as I imagine remote communities also have to deal with. So the great thing about the VODOT is definitely ability to see more patients, be directly available to patients, and from the patient's perspective, they were also a little bit concerned to have anybody else in their home in the context of COVID. So it was really helpful in those contexts. One of the cons, though, I have to say, I think what already was mentioned, is that with some of our higher needs patients, we did have to move to doing a combination of community in-person DOT visits as well. Just that some patients just weren't really able to manage through VideoDot. Some patients really needed that in-person support because they were struggling with other health issues or addictions issues. So that in-person care does go a long way for some of our higher priority patients. But definitely the VideoDot, we would not have been able to manage our cases with the limited resources without moving to using WhatsApp for VDOT.
Great. Thank you so much for sharing that experience, Julia. Very much appreciated. So Cheryl, I think you're right. We're still in the understanding the pros and the cons of virtual dots and how to make it work for everyone, or use a hybrid model. Okay, so now, without further ado, drum roll. We are officially launching our report with findings and calls to actions, looking at the impact of COVID-19 on TB programs in Canada. Lee is going to share the link in the chat box so that everyone can go and read that for themselves now. And we are very lucky to have a number of influential people in the room ready to respond to the report with some observations and closing remarks for this session. Please bear with us if we go like 5 minutes over 2 o'clock. We'll try and not keep you any longer than that, but I want to make sure everybody has their 2 to 3 minutes max intervention in terms of their response to this initiative. And we are going to start by hearing from Tina Campbell, who is a member of the Stop TB Canada Steering Committee and works as a TB nurse with the Northern Intertribal Health Authority. So over to you, Tina. I will get you on Spotlight.
Good morning, everybody. Morning over here, afternoon in Ontario. Thanks for joining us today for this very important discussion. I would like to acknowledge that I'm talking to you today from Treaty 6 territory, the traditional territory of the Cree and the homeland of the Métis people. So I work for Northern Intertribal Health Authority in Prince Albert, Saskatchewan. I'm a TB advisor. Our program has currently 3 full-time nurses that are working, and we look after 33 First Nations communities. So that's a pretty small team for a large number of reserves. Only 2 to 3 minutes. I could go on and talking about the impacts that COVID-19 has had on our TB programs. Just to give you some context, last year this time we had I believe it was 13 cases up to date, and now currently we have 28 cases in 2021 just from January 1st. Elizabeth had mentioned that there were recently 2 outbreaks declared in northern Saskatchewan. Those 2 communities fall under NIFA's jurisdiction. So we're very busy right now. All of our nurses are deployed to the communities. I've had to reach out to Indigenous Services Canada to offer some more nursing support. Previously to this, I kind of figured that something like this was brewing because our TB patients that were diagnosed were very, very advanced stages in disease. A number of them too were symptomatic for a number of months, consistently being tested for COVID, found negative, and nobody, I guess, because of the resources, all of our communities too have short staff. And I think last time I checked, there was over 13 communities also in a COVID-19 outbreak currently. So trying to manage moving forward and sending nurses in to assist with the TB programming, with contact investigations, there can be barriers and stuff going into the community. People are hesitant to, open the doors to anybody coming in to do any assessments. So what else can I say? So in terms of, I just wanted to answer to the DOT, the virtual DOT. Unfortunately, in our communities, it hasn't really been successful. I know in southern Saskatchewan it has been, but there's the majority of other things that impact that. Cell service, Wi-Fi access. If people have cell phones, maybe they don't have minutes. So DOT, I'm always such a big advocate of DOT because especially in remote communities, that TB worker or the DOT administrator is that link between the patient and TB care. So I think that's great because we can support them all the way through treatment. And that continues through COVID. We have to really give a big shout out to our TB program workers working during these very stressful and uncertain times, continuing to provide DOT. And all the nurses as well, frontline. I know it's just, overwhelming with all the people that they're seeing for COVID screening. And then people don't normally think about TB, but we've started a messaging campaign as well to get TB into the minds of all our healthcare practitioners as well as community members. So we're encouraging people that if they are symptomatic and COVID-19 is ruled out to request a TB test. I'm sure I have tons more to say, but I'll just leave it at that for now. I've been working in TB for over 10 years now, so I'm very passionate about it. And I'm very honored to be a steering committee member for Stop TB Canada.
Thank you so much, Tina, for sharing your experience. Okay, now we're going to go over to Dr. Carolyn Pym, who is a TB program consultant, highly engaged in Nunavut. So Carolyn, over to you. Sorry, we're changing up the order because Carolyn was going to have to drop off. Carolyn.
Okay, thanks very much, Robin, and thank you very much for those of you who did this study. I think it's really important for re-engaging and re-energizing both ourselves and the people we're advocating to for appropriate TB action on TB elimination. In terms of reflections, I did note that there was not the data from or information or input from Nunavut. I can provide just a little bit of an update. I think many of the observations and responses in the in the report are similar or were similar in Nunavut. I think obviously the health human resources shortages and redeployment of people was significant all across Canada. But as you know, in northern communities, it really just exacerbated, you know, an acute on chronic challenge with expertise, both the number of professional nursing staff as well as people with TB expertise. So you know, what you know, most people on the call would, I'm sure, would agree that you know, just having a nurse in general is, you know, they obviously have a huge number of skills, but if they don't have a lot of experience with TB, then it does create challenges. So in terms of for communities in Nunavut that had COVID outbreaks, there definitely was change in care. Not a lot of options for virtual care, although I'm really interested in what Julia said about the VDOT. So I'd like to pursue that a little bit more. Sorry, the VDOT using WhatsApp. Because, you know, some communities don't have adequate mobile network coverage. Obviously, interruption of some of the lower priority screening programs. And not only impact at the you know, direct patient or client care level, but also at the central level. So central level people redeployed so that things like epidemiology support for TB programs. When you only have one TB epidemiologist and they're doing COVID, then, you know, you can't move that ahead. Central planning, you know, working on TB elimination. Those things fell by the wayside, and also research and evaluation projects that could not go forward because of redeployment. So just I've got lots of other little tidbits, but in terms of the positives, I think a couple of positives from COVID outbreaks. Communities with COVID outbreaks is using actually providing clients with mobile phones. So that they could be reached if they didn't have one for either contact follow-up or treatment. And also in COVID, people who are in isolation, there was development of isolation kits that could be provided to support people in their isolation period. And the TB program has always had enablers and incentives, but you know, just recently we've managed to access that resource for TB, which wasn't available in the past. And someone also mentioned in the chat box about expert. I think that really has potential, and I do hope and think that that will be explored in terms of expanding that across the territory. So similar issues, obviously very different contexts, but thanks again for this report.
Thank you so much, Carolyn. It's really valuable to get your insights. So now we are moving over to Dr. Richard Long with the Department of Medicine at University of Alberta, who was absolutely critical to making this project happen. So over to you, Dr. Long. I will spotlight you.
Thank you, Robin, and thanks very much to the steering committee for inviting me to say a few words. I'll try and be brief. First, really want to commend Stop TB Canada for taking the initiative here. The Canadian TB Elimination Network is sort of a network of community of practice in Canada. Tried to get this off the ground quite a while ago, but were unsuccessful. But great that Stop TB could move it forward. We might have hoped, clearly, we might have hoped that responding to the threat of COVID-19 would not come at the expense of essential TB services, but clearly it has. But I like to, as others, Carolyn and Dick and others have said, you know, we've got to take the good away from this and learn. And clearly, gaps identified here in the survey point to the pressing need for better TB surveillance. the capacity to share data across jurisdictions and sectors, as well as at the community level. It has to happen. The application of well-established public health principles in the fight against COVID offer a unique opportunity for Canada to improve TB services. Critically important to this and to TB elimination, which we are not doing very well in, is the proactive federal, provincial, and territorial coordination and cooperation. This has to happen. It's so long overdue. And I know Elizabeth has alluded to this, and it's just critical. Finally, I would just add that the social failures exposed by COVID, the societal failures exposed by COVID have long been known to us in TB services. These are not new, but clearly we have work to do to grant everyone the right to health and to make improvements in health equity and matters of social justice. So there are larger issues at stake here that we in the TB community have a duty to move on. So I'll maybe stop there.
Thank you so much, Dr. Long. We really appreciate you being here today and for all your support in making this happen. We're going to head over now to Dr. Richard Menzies, who is the Canada Research Chair in TB Research and the Director of the McGill International TB Centre. And following him, we just have one final intervention before we wrap up. So stay with us, everyone. Over to you, Dr. Menzies. I'll spotlight you.
Okay, thanks, Robin. So yeah, so my thanks again to the Stop TB Canada and also to the investigators and facilitators and of course respondents also on the survey who must have taken time out of their COVID activities to respond to the survey. Yeah, I think, you know, again, the lessons are there to be learned, and I think, you know, the best we can do is to try to move forward and say, well, what can we do to mitigate the effects of the ongoing pandemic, which still isn't over, but also how can we try to convert lessons learned and some advantages into positive things and strengthen TB programs going forward. That would be really, I think, where I would focus attention in follow-up to this, you know, important work that's highlighted some of the difficulties encountered and the difficulties that it's created, is how to turn that into something positive, in part because I think, you know, decision makers always prefer to hear that. And in part because, you know, I think there is an opportunity now in the next 12 months to try to steal some resources back and maybe do a little better going forward. Thanks.
So glad you elevated engaging with decision makers. Our next steps as a steering committee are to send the executive summary of this report to newly elected members of parliament and to engage the new ministers as soon as we know who they are. Cabinet will be announced October 26th. So this is really timely, and we're going to be pushing really hard on making sure all those calls to actions are prioritized by our political leadership. And last but not least, we have a final intervention from Andrea Monaghan of Indigenous Services Canada. Andrea, are you still with us? Over to you, I'll spotlight you.
Yes, I am. Thanks so much, Robin. So I'm grateful to be joining this call today from the unceded territory of the Algonquin Anishinaabe people. I'm the National Program Coordinator for the TB program at Indigenous Services Canada. And I just wanted to say that I really appreciate the work that's been done by Stop TB Canada to conduct this survey and share the results with us. We are hearing anecdotally from colleagues across the country that COVID-19 has significantly impacted their TB programs, whether that be through the reallocation of staff, the impact of lockdowns, or other reasons that can be attributed to the pandemic. And so it's really important that we now have access to Canadian data that reflects that, those things that we've been hearing anecdotally. So our program will certainly be reviewing this report in more detail, especially around the ways that programs have adapted to provide services during the pandemic and the opportunities and needs for TB programming post-pandemic as well. And we're really looking forward to using this report to inform our program planning and our support to regions and partners. Thank you again.
Thank you so much, Andrea. Great to have you here today, and it's awesome that we have allies within Indigenous Services Canada that we can collaborate with to create the greatest impact possible and ensure that TB elimination goals are met here in Canada. And just pointing out, Elizabeth, yes, of course, engaging at the provincial and territorial level as well is a next step for the steering committee. So we are 5 minutes over. I knew we were going to be about 5 minutes over. My sincere apologies for that. Did try to stick to time, but it's really great to hear from all of the diverse speakers that were with us today. If you want to stick around to workshop next steps with us, or if you have any additional questions, you can, because some of us are going to be staying on till 3 to engage in a bit of a strategy discussion. And if you are not yet engaged with Stop TB Canada, please sign up for our mailing list, which you can do so by going to any page of our website and scrolling down, just input your email address. That's where you'll hear all from everything we're doing, what we're getting up to, why we're getting up to it, and you can start to participate and engage with this community as and where you like to. It would be really lovely to have you on board because we are more powerful together. Okay, thank you everyone. Really appreciate your time today.